Good morning, friends. Today's webinar is supported by RPG Life Sciences, Building Healthier Future, Discovering and Developing Global Healthcare Technologies to Enhance the Quality of Life. RPG welcomes to the Engaging Science Initiative. Mumbai Hematology Group, supported and managed by Mice Ideas. I thank Mr. Ajit Mule Mr. Sudhir Ambekar and their team from RPG for supporting our academic activity this morning, Mr. Rajesh Sharma, Mr. Kalpesh Pambar and their team from Ice Ideas for managing the show, Executive Committee of Mumbai Hematology Group, our chief guest this morning, Dr. Cecil Ross from Bangalore, our guest speaker, Dr. Paul from Iceland. All our discussants were themselves eminent hematologists or hematopathologists, new participants for sparing your Sunday morning. Our guest speaker this morning is Dr. Paul Torfi Onenderson from Reykjavik, Iceland. He's going to lecture us on monitoring the warfarin therapy, PT-INR or Fiix-PT, Fiix-NR, something which is his own invention. Just to introduce you to the next weekend activity, Saturday evening, 25th of December, 7 p.m. onwards, we have Dr. Gaurav Kharia from Delhi speaking to us on curative option for sickle cell disease. And next Sunday morning at 11:30 a.m., we have Journey of Hemophilia Towards Cure by Professor Chandrakala from KM Hospital, Mumbai. To introduce Dr. Paul Torfi Onenderson in full details, he is Professor of Hematology, Faculty of Medicine and Surgery, Head of Hematology Lab, Thrombosis and Hemostasis Services, Lengspitali University Hospital, Reykjavik, Iceland. He was trained in internal medicine under Frank Davidoff at the University of Connecticut, New Britain, and Farmington. This was from 1984 to 87. Subsequently, he was trained in hematology under Marshall Lichman, Victor Marder, and Jacob Rowe, and Charles Francis at the University of Rochester Medical Center, Rochester, New York, from 87 to 91. He has over 30 years of experience in hematology and lab hematology with emphasis on thrombosis and hemostasis, including care of bleeding disorders. He heads the anticoagulation management services. He is co-inventor of the Fiix test, which is a patented modified prothrombin time that is affected by factor 2 and 10 only and not by factor 7. The Fiix-PT stabilizes the warfarin effect, leading to major clinical benefit, and that's what he is going to explain us today. This work of his, the invention of his, was reported in the Lancet Hematology in 2015, followed by a second confirmatory study that was published in May this year in Blood. The Fiix test has been marketed as a CE marked product by manufacturer Hart Biologicals as of June 2020. And the idea is that replacing PT-INR monitoring of vitamin K antagonists with Fiix-NR monitoring reduces testing, reduces dose adjustments, and improves the efficacy by over 50%. All these you are going to hear for next 45 minutes. Our discussions this morning include faculty from Mumbai, Kolkata, Kochi, Ahmedabad, and Pune. We have Dr. Faraj Jijina from PD Hinduja Hospital, Mumbai. Dr. Srimati Shetty, former scientist F, Deputy Director, Senior Grade from NIIH ICMR, KM Hospital, Mumbai. Professor Chandrakala from St. GS Medical College, KM Hospital, Mumbai. Dr. Bipin Kulkarni, Scientist D, Assistant Director, Head Department of Hemostasis and Thrombosis at NIH ICMR, Ministry of Health and Family Welfare, Government of India, KM Hospital, Parel, Mumbai. Dr. Rucha Patil, Scientist B, NIH ICMR, again KM Hospital Campus, Parel, Mumbai. Dr. Dheeraj Bhattar, who is Consultant in Internal Medicine and Hematology at the prestigious Sir H.N. Reliance Foundation Hospital, Girgaon, Mumbai. Dr. Pranta Chakrabarti, who is Hematologist, Fortis Hospital, Nightingale Hospital, Vivekananda Institute of Medical Sciences, Apex Institute of Medical Sciences, Kolkata. Dr. Manoj Unni, Associate Professor, Department of Hematology and Stem Cell Transplant Unit at Amrita Institute of Medical Sciences, Kochi. Dr. Akanksha Garg, Assistant Professor, Hematology and Transplantation, Department of Medical Oncology at GCRI, Ahmedabad. Dr. Anusri Prabhakaran, Consultant Hematologist, Dinanath Mangeshkar Hospital, Pune. After this, we will just introduce our students and others to the Sunday quiz as usual. Today's quiz is related to sickle cell trait. You will have 7 statements. One of the statement is wrong. You pick up the wrong statement and email the number of that statement to mbagarwal1@gmail.com. And the winner will be fastest finger first. And of course, we will tell you names of all those who forward the correct reply to this quiz. So one of the statement is wrong. There's a number to that statement. Just that number is to be emailed. And the fastest finger first will be the winner. I'm going to read out these 7 statements to you. Some of them are longish. But we'll go through all of this because this quiz is not only a quiz, but also an educational exercise. So we are talking about sickle cell trait. Hemoglobin S is due to a point mutation in the beta globin chain. This point mutation replaces A with T at codon 6 of beta globin chain, causing switch from glutamic acid to valine amino acid. 2. Worldwide, there are 300 million people carrying sickle cell trait. 1/3 of these are in sub-Saharan Africa. In US, there are 3 million people with sickle cell trait. 3. Sickle cell trait gives protection against death by falciparum malaria. 4. Hemoglobin S percentage in sickle cell trait is usually around 40%. However, if there is associated iron deficiency or beta thalassemia carrier state, the hemoglobin S percentage could be as low as 20%. 5. In US, there is mandatory newborn screening in all 50 states for the sickle cell trait before a newborn is discharged from the hospital. 6. Sickle cell trait is typically an asymptomatic carrier state. However, complications can occur under extreme conditions. These complications include hyposthenuria, renal papillary necrosis, asymptomatic bacteriuria in females, hematuria, renal medullary carcinoma, chronic kidney disease, venous thromboembolism, splenic infarcts, exertional rhabdomyolysis, heat-associated collapse, and unexpected sudden death following exertion in athletes, police, and military recruits. And 7th, despite all these complications, the average life expectancy of people with sickle cell trait is same as that of general population. So out of these 7 statements, one of the statement is wrong, and whatever is the number of that statement, 6 or 7 or 3 or 2, that number is to be emailed to mbagarwal1@gmail.com. And now it's time to introduce our chief guest for the day, and we are honored by the kind presence of Dr. Cecil Ross from Bangalore. No one in this country who has anything to do with hematology, this name is not familiar. Dr. Cecil Ross obtained his MBBS from St. John Medical College, Bangalore, followed by MD from the Government Medical College, Bellary in 1986. Subsequently, he acquired specialized training in hematology from CMC Vellore, followed by Royal Free Hospital, London, and Central University, US. He started the hematology services at St. John in 1990, that is 32 years ago. He is the founder member of the Hemophilia Society, Bangalore chapter. He is the National Vice President Medical of Hemophilia Federation India, and he has done many clinical trials in hemophilia and other bleeding disorders. He was responsible for formation of the National Hemophilia Registry in India, and he was awarded Twin of the Year program by the World Federation of Hemophilia and GLUE grant from the DBT India. I request Dr. Cecil Ross to inaugurate our today's webinar and also give us some words of wisdom. Over to Dr. Cecil Ross.
Thank you, sir. Thank you for the kind words. It gives me a great honor to be recognized by the Mumbai Hematology Group as a guest today, chief guest today. I would like to say that the reason that I am in the field of hematology has much to do with the inspiring mentors that I had during my training at CMC, at Royal Free and St. Louis. But many of my patients with MDS, acute leukemia, bleeding disorders have been my inspiration, who I saw as an intern, as a PG, postgraduate, as a fellow, and finally as a faculty. Especially when you see the relapsing nature of all these disorders, the patient's disease, who underwent arduous medical treatment, they inspire you because they go through a lot, and they actually inspire you because you may have many disappointments on the way, patients who don't do as well as you hope to, and some experimental ideas that didn't work out. But for that, you must have the resilience to join the patient in his journey, which can be sometimes very difficult and depressing. Clinical hematology is the only specialty, to my mind, which you must learn genomics, epigenetics, developmental biology, and skills of a good internist to have resilience to handle all these issues. When you look at hematology back, and I suspect it's other subjects also, but especially in hematology, everyone has their own role models in their lives who inspire you to choose a career in hematology or in medicine. You model yourselves on your heroes, setting up a personal shrine, small images of these heroes, and the shrine expands as you progress in your career. Mumbai Hematology Group and Dr. M.D. Agarwal devote a significant part of their own intellectual bandwidth to advance others through programs like these. And it helps develop careers, patient care, and research. And if all this goes well, it is one of the most exciting areas of internal medicine. Hematology is one of the most exciting areas because you can have targeted therapies at a molecular level and make lives of many patients simple. So thank you, Dr. Agarwal, for all your initiative and your motivation for all the people who wish to take hematology as a career. Thank you.
Thank you, Dr. Cecil Ross, for those kind words and sparing your morning and blessing Mumbai Hematology Group, all our participants who are not only from India, but from various parts of Asia and also other parts of this world. And now, of course, over to our guest speaker for the day, Dr. Paul. It's all yours. Please go ahead with your lecture.
Good morning, everyone. I hope you can see my slide.
Yes, sir.
And I hope you're not seeing my lecture notes, but only the slide. Now, Dr. Agarwal, Dr. Ross, and dear colleagues, it's my pleasure to be invited to speak for you this morning. It's 6 a.m. in Iceland, in Reykjavik. It's pitch black because it's almost the darkest day of the year. There's hardly any daylight for the next coming month, in particular when it's raining like it is today. I will be talking today about our new Fiix test, and I must first disclose that I'm not without conflict of interest because we invented this new test, or I invented it together with Brynja Guðmundsdóttir, who is my partner. And we have a patent issued on this test. The test has been marketed in Europe. It's a CE marked product made by Heart Biologicals, and if you want more information, you can actually either visit their website or you can visit a website called Fiix-PT.com. And it should be a double I, Fiix-PT.com. In any case, what I will be talking about is based on publications that we've been writing in the last 10 years or so. We started working on this in 2009, and these are the publications. And basically, our conclusion is that for all the 70 years of the use of warfarin and other vitamin K antagonists, it has been monitored with the wrong test. We have been monitoring the wrong effect. And this is one of the reasons why we have all the fluctuation in the effect that we see. And if you want to read only one of these papers, there is a new review article that came out in the Thrombosis Journal just in September or October. And that would be a good start instead of reading all these articles. And most of you have a lot of articles to read. But the new article, the review article, is an open access article, so available to everybody. Also, before I start, I will talk a little bit about the terminology that I use. I will always talk about DOACs, which means direct oral anticoagulants. Some people call them NOACs, even if they are not new anymore, or SOACs, target-specific oral anticoagulants. But I will use the term DOACs. When I talk about INR, I call it PT-INR. That's the traditional prothrombin time-based INR for VKA monitoring. And I talk about Fiix-NR, that's fixed normalized ratio, which is a normalized ratio that we calculate based on our modified fixed prothrombin time. Then I will talk also about PT warfarin, and by that I mean warfarin that is being managed by monitoring factors 2, 7, and 10 using the traditional PT, either the quick prothrombin time or the orange. We tend to use the orange PT in Scandinavia and in Holland and in Japan, but most of the world uses the quick PT. And then I talk about fixed warfarin, which is warfarin managed by the new test, which monitors only factors 2 and 10 and ignores factor 7. The Fiix-NR is calculated in a manner that's quite similar to the PT-INR. And this is sort of what I will be talking about. I think I got until about it's 6:20, so now I've got about 40 minutes to talk about this. And I will sort of address why do we anticoagulate? Is one agent better than the other now that we have a choice? And can we improve oral anticoagulant outcome? And then finally we will get to the new test and what we have found in our studies. First, why do we anticoagulate? And it almost seems like we are doing it to prevent bleeding, but we in the West, because people talk so much about the bleeding. But the reason that we anticoagulate is that there are people that are at a high risk of dying or getting a major disability from thromboembolism. And this has to be present for us to choose to anticoagulate somebody. I would not like to take an anticoagulant unless if I had one of those conditions, because anticoagulation with the current agents inevitably comes at the cost of increased bleeding. So the benefit must weigh more than the risk. And this all of you obviously know. There is, in the last few years, we've seen some extra bonus of anticoagulation. Like, for example, there are studies that I'm showing here from Denmark, and there are other such studies where they found that in atrial fibrillations, patients that get anticoagulation, they have less dementia. And it doesn't seem to matter. It's observed both with warfarin and also with the new DOACs. In one of the studies from Denmark, they actually found that there was less dementia with warfarin than there was with what they call the NOAC agents. You can see it here in the slides. I better use the laser pointer to point this out. And then an interesting extra benefit that they found in a huge study from Norway. They studied 1.2 million people because they have all the medical records are electronic. And they found that in patients with atrial fibrillation that are anticoagulated, they have a reduced cancer incidence, even by about 40%. So, and this is considered to be an effect of warfarin on a tyrosine kinase that will, so it is a direct anti-proliferative effect and probably has nothing to do with the anticoagulant effect. I'm starting to make it sound as if it's good to be anticoagulated, but I think it's something that is only a necessity, for some patients. So we are not going to use this, at least to the drinking water. But now in the last 10 years or so, we have lived in an era of anticoagulant choice. And sort of what I'm wondering, and you are all wondering, is that is one oral anticoagulant more effective than another, or is it all about the right management? This is sort of the development or anticoagulation history in one slide. And you can see that for the first year, 60 years or so of it, starting in about year 1950, we've used the only oral anticoagulants that we had were the vitamin K antagonists. And then after 2009 or the beginning of 2010, we are in a new era called, we can call the NOAC era or the DOAC era. I would like to call it the era of anticoagulant choice, because now we have the option of prescribing direct oral anticoagulants or warfarin, and we can choose between different agents. In the West, the pendulum has been swinging has been swinging to the right, namely that we are using more and more of the DOAC agents, and I contend that it's actually being pushed to the right. So these are most of the current anticoagulation guidelines in the Western world. For atrial fibrillation, we use DOACs as first line and the vitamin K antagonists as a second line, and the same thing for venous thromboembolism. And the key opinion leaders in the field, they claim that there is similar or improved efficacy, but less bleeding with the DOACs. And I guess here, I'm going to review the evidence, and I will sort of contend that it may not be all that easy. So first, let's look at the medium thrombosis risk patients that need anticoagulation. So we're talking about non-valvular atrial fibrillation, and we're talking about venous thromboembolism. First, it is sobering to look at the initial data on warfarin in non-valvular atrial fibrillation, because the initial studies, and they are done early in the 1990s, so it's almost 30 years ago, where they find the major benefit of warfarin anticoagulation compared to placebo. And indeed, the effect was so great that nobody has done placebo-controlled studies since the 1990s. So because it was found that in the first study by Esekovich in Boston, they found that there was a 79% decrease in annual cerebral infarction rate when patients received warfarin compared to no anticoagulation or placebo. The rate decreased from 4.3% to 0.9% annually. And then there were a few other studies, and Hart and colleagues, they wrote a meta-analysis which was published in 1999. And you can show that they found that overall there was a 64% decrease from about 6% annually getting strokes and systemic embolism to about 2% when you use warfarin as the yellow compared to the red, which is placebo. Then we got the new oral anticoagulants, and you can see that in one of the meta-analysis, which is being quoted a lot by Ruff and colleagues, they found that there may be a 19% improvement over warfarin if you use the DOACs. And what I will be showing you is that if we improve warfarin by using the new test, we may actually be able to decrease thromboembolism even further. I'm sure that a lot of people will find what I'm saying to be controversial, and this we will talk about in the discussion later on. So this is the meta-analysis of Ruff and colleagues, and these are all the main authors of these pharmaceutical company trials in atrial fibrillation, where they compared their new direct oral anticoagulant with warfarin. And you can see, if you look at those names, that these are the major key opinion leaders in the field of anticoagulation that wrote this meta-analysis. And I'm a tiny little midget when I compared to these people, and I have an opposing view of what they say. So basically, what they found, there was overall there was a 19% decrease in thromboembolism. But basically, these trials, all of them have been criticized because they all used poorly managed warfarin in the control group. And you wonder why do you, if you're gonna see if a new drug is better than an old one, why do you compare it to a poorly managed control group? And you can all imagine why. It's to show that there's an improvement with the new agent. But how meaningful is it to get such a result? It may be meaningful, if you're unable to treat adequately with warfarin, then it's meaningful that you can actually use the new agent. But if you live in an area where you can actually give good warfarin management, you may actually think about the cost and other things about the warfarin. There have been a lot of problems that have been identified with these trials, including that there have been falsified data, with underreporting of bleeding, like in the Aristotle trial. And this was published in the JAMA. There were people from the FDA that wrote the papers in JAMA that there had been falsified data and underreporting of bleeding. And likewise, there was a suspiciously low bleeding incidence in the RELY trial. There were problems in the ROCKET trial with warfarin being overdosed because they used a faulty instrument to measure the INR, and so on and so on. But I guess it's hard to do the perfect clinical study. This is just a meta-analysis of the trials in venous thromboembolism, which show that according to the pharmaceutical company trials, it seems to be that treatment with the DOACs gives similar results. The efficacy is similar to what you find with warfarin. However, also in those trials, they used rather poorly managed warfarin. So what about high thrombosis risk patients? Patients with mechanical heart valves with the lupus anticoagulant syndrome, post-anterior wall MI. And interestingly, it has been found that warfarin is more effective than the DOACs in these conditions. The study I'm showing here is called the REALIGN study, which is published in 2013, comparing dabigatran to warfarin, and they found that there was a higher incidence of thromboembolism and bleeding with dabigatran than with warfarin. And the trial had to be stopped early because the difference was significant. And after that, the recommendation is to use warfarin for those patients. Likewise, there are now 3 trials, 3 prospective studies that have shown that in patients with the antiphospholipid antibody syndrome, warfarin is much more effective than our rivaroxaban or apixaban. So patients that have an antiphospholipid antibody syndrome should receive warfarin, and the current guidelines they reflect this. But sort of the question comes: how come that warfarin is more effective than the DOACs in high-risk patients, but not in moderate-risk patients? What could explain that? Well, it could be that there is a different thrombogenic mechanism, or maybe it's possible that warfarin is actually also more effective in the moderate risk patients. And that's sort of my conclusion, is that we have to keep in mind that this may be true. Maybe there was some kind of a patient selection in the clinical trials, or maybe the poor warfarin management in the clinical trials is the reason why we don't see why the DOACs appear to be better in those patients. Now, while I'm saying this, I'm focusing very much on the efficacy, and I have not been talking much about the bleeding, which we will come to that. Now, what about the real world data, something that's outside the clinical trial scenario? This is a real world study of about 40,000 people from Denmark, where they compared compared stroke or thromboembolism or ischemic stroke with the different agents. And basically what they find is that for the 6 months or so of treating with oral anticoagulants, there is no difference. But then after a while, the highest incidence of stroke and systemic embolism is seen with apixaban, the green. The second highest with rivaroxaban. The red is dabigatran, and the lowest incidences with warfarin. So I think you would have to conclude that warfarin must be at least as good as the other agents, and my suspicion is that it's actually possibly better. Here's another real-world study from the USA. They had studied 130,000 patients and studied the incidence of ischemic strokes in patients taking novel oral anticoagulants versus warfarin. And basically, what they find is that there is reduced incidence of intracranial hemorrhage with the DOACs. But so you can see that they have about 67,000 patients treated with the DOACs, and they have 57,000 with warfarin. And you can see that when you treat with warfarin, you have about 77 more cases than you have if you treat with the DOACs. But at the same time, if you look at the left panel, you can see that there is a 30% decrease in ischemic strokes in the patients treated with warfarin. And it's an order of magnitude more. So this means that there is about, it's almost 1,400 patients less that develop an ischemic stroke with warfarin than there is with NOAC. So the benefit, you have to think about it, that the strokes leave a permanent damage, in maybe half of the people, and about 20% of the people die if they get a stroke, and others are left with paralysis or other chronic problems. So even if it's serious to get an intracranial hemorrhage, there's just 10 times as many people that will get an ischemic stroke. So you have to weigh that in. You have to think about that scale that they showed you, that when we are estimating the benefit of these agents. This is a study that came out just a couple of months ago in the Journal of Hematology and Oncology. And this is an interesting study of, this is 370,000 patients on warfarin or DOACs in Great Britain. And basically, this is during the COVID pandemic. And what they find is that there is a 20 to 25% lower mortality in patients treated with warfarin than in those with the DOACs. And the decrease in mortality is both from COVID-related complications, but also from non-COVID related conditions. So again, there's evidence there showing that patients on warfarin actually fare better, and this is the definitive endpoint, death. Also now in the summer and in the fall, there have been a couple of papers coming from the Beth Israel Hospital in Boston, where they've shown that patients with cancer-related thromboembolism survive longer if they get warfarin compared to low molecular weight heparin on the left or the DOACs on the right. So where do we stand now in December 2021? Well, we have the DOACs, and there is no question that they are more convenient because you don't monitor them all of the time. And there is less intracranial bleeding. And then we have warfarin here on the right scale, and there's more intracranial hemorrhage, and there's need for monitoring tests. But with warfarin, there seems to be lower mortality, and there seems to be less thromboembolism in real-world practice, and it's of course much cheaper. So now we come to the question: can oral anticoagulant outcome be improved? And I'm focusing only on can warfarin outcome be improved? And I'll tell you that it's a lonesome task to try to improve warfarin in the last 10 years. I mean, who is interested in warfarin? It's difficult to manage, and it's that cheap. And all of the Western world, key opinion leaders have turned against it. So having an interest in warfarin makes you feel quite alone. So here you can see this lonesome little investigator. He is pale and poor, and he is going to fight the giants. And if you're going to fight the giants, which have all the support here of the world's cardiologists and hematologists, you better hit the giant right between the eyes. And it's not very likely that you will succeed in doing that. And again, the same slide, just to remind you. So warfarin is a highly effective drug. But the question is, can warfarin outcome be improved further? And you all know this kind of a U-shaped curve, that we do have a therapeutic area where we have maximum efficacy and we have minimum increase in bleeding. And we know that once the INR hits about 4 or 4.5, we get an exponential rise in the risk of bleeding. But the main problem really is trying to keep the patient within that range, because the patients tend to slip out of the range. So the anticoagulation is unstable. And we know that the quality of warfarin management affects the efficacy considerably. So this is a study of 44,000 people in Sweden by Björk and colleagues, where they show that if you're able to keep the time within target range consistently over 70%, they have the lowest rate of thrombosis and bleeding or intracranial bleeding. And also, if you have an inconsistent effect, that there's lots of fluctuation or variability, you will have a higher rate of the untoward events. So again, what is the main problem during warfarin management? And in my opinion, it's variable INR. There are many problems, but a variable INR is the main problem. After the initiation, there's a dose finding period, the initiation period where you may discovered that some people only need 1 milligram and some people will need 15 milligrams daily. But once you have found out what is the likely dose range, this becomes the main problem. And we tend to think that the variability is caused by these issues. There are food interactions, vitamin K rich food. There is drug interactions. There are patient compliance problems. There is unstructured dosing by guesswork. People don't use some kind of a dosing algorithm or a software, and they don't have an anticoagulation management service. These would be the main causes of the variability. The metabolism really has not much to do with the variability. It's more about which dose the patient needs. But strangely enough, not many people, for the 70 years of use of warfarin, there have not been many people that have wondered if the prothrombin time is really the right test to use to monitor warfarin. So why do we use prothrombin time to monitor vitamin K antagonists? And I'll tell you the answer is very simple. It's historical. It's only historical reasons. When the PT was invented, there were only 2 proteins known in the coagulation cascade, fibrinogen and prothrombin, and only prothrombin was found to be vitamin K dependent. And then when the people started experimenting with warfarin, or actually initially with decumarole back in the 1940s, they considered that the effect was brought about by reducing prothrombin, because they didn't know about any other factors. And but later, gradually, we discovered more and more factors. Factor 5 was discovered in 1944. That affects the prothrombin time. Proconvertin, or factor 7, discovered in 1949, and then Stewart factor in about 1960. And factor 9, of course, which does not influence the PT, is also a vitamin K dependent factor, discovered in 1958, I believe. So gradually we got to know that that the PT was influenced by 5 factors, and that 3 of them were vitamin K dependent. All the time, and ever since, people have considered it to be important to reduce all of the vitamin K dependent factors, and very few people have investigated if these factors have a different weight in developing the antithrombotic effect. However, Konrad Hemker and his research group in Holland, they thought about this. Well, this has been 30 years ago. They did this study by C and colleagues, and they found that actually, if you look at the factor concentration here on the x-axis, you can see that as the factor concentration decreases, the thrombin generation decreases linearly. You know, when you look at factor 2. When you look at factor 10, it starts to decrease once you hit about 30% factor. Then with factor 9, you have to hit about 10%. And it isn't really until factor 7 is about 2.5% that it starts affecting thrombin generation. Now, this was an interesting study, and I don't want you even to try to read, just listen to what I say and don't even try to read this. Samuel Rappaport in La Jolla in California, they did an interesting experiment. They infused rabbits with thromboplastin. When you infuse rabbits with thromboplastin, they all get DIC and they die. He then showed that if the rabbits had been deeply anticoagulated with warfarin, and they got the thromboplastin infusion, they did not die. They did not develop DIC. And then they followed up on that by immunodepleting the rabbits of factor 2 or factor 10 to about 10 to 15% activity. And then the rabbits did not develop DIC. If they immunodepleted factor 7 or factor 9 to the same level, all the rabbits got DIC and died. So you really had to immunodeplete them to a much lower level of factor 7 and factor 9 in order to prevent DIC. So this was consistent to what Konrad Hemker's group had shown. Now, this was our studies, and we published this in 2012. And here we were looking at the effect of each individual factor, vitamin K dependent factor, on the quick prothrombin time. And basically showing that reducing any of them, we're reducing a single factor at a time, and we get exactly the same effect on the prothrombin time. So if we reduce factor 2 to about to 10%, say, you get the same prolongation of the prothrombin time as you get with factor 7. Of course, the factor 7 measures a combined effect, but it's more complicated than just the influence on the test, because these coagulation factors have a different half-life in patients. Factor 7 has a half-life of only 4 hours, and factor 2 has a half-life of about 72 hours, and factor 10 about 48 hours. So you can tell then that in the short term, it's factor 7 that decides what the prothrombin time or the PT-INR will be. In the long term, it's going to be more factor 2 and factor 10. So, and we've also seen from the study by Sivelin, or the one from Rappaport, that they have a different biological effect. So this is more of the studies that we did. This is the same study again. This is the undiluted prothrombin time. We then did further experiments looking at the contribution of each of the coagulation factors to the thrombin generation. And if you look just on the right, this is the thrombin generation experiments, and you can see that the pink column that I'm showing here, that's the concentration of factor 2 that you observe during controlled anticoagulation with an INR of 2.3. Factor 2 will be in the range of 20 to 40%. And factor 10 is lower, it's about 10 to 20%. And you can see that at those levels, both factor 2 and factor 10 will influence thrombin generation. However, at those kind of levels, there is no influence by factor 2 or factor 9, shown here as the black and the green. So it's really at a therapeutic range of the factors, it's really only factor 2 and 10 that influence thrombin generation. And surprisingly enough, the factor 7 and factor 9 concentration is higher. It's about 20 up to 80% in these patients with stable anticoagulation. And this is probably because they're fluctuating a lot. So why are we using a monitoring test that is markedly affected by factor 7 if factor 7 has nothing to do with the antithrombotic effect? It occurred to us that the PT should and could be fixed. And we hypothesized that the marked influence of factor 7 on the PT-INR causes clinically irrelevant PT-INR variability and confounds vitamin K antagonist management due to its short half-life. And secondly, that measuring the coagulant activity of only factor 2 and 10 while purposefully ignoring factor 7 at the same time would more accurately reflect the warfarin anticoagulation than the PT does. So we invented a modified PT that is only influenced by factor 2 and 10. I think I've got it here. And basically what we do is we make a reagent that's deficient in factor 2 and factor 10. We call it Fiix, a Fiix deficient plasma, and it has normal, all other concentrations are normal. And we then we mix this into the patient sample, And that by doing that, we correct for any kind of factor deficiency in any factors other than factor 2 and 10, and then we measure a prothrombin time. So the prothrombin time that we measure is only a reflection of factor 2 and factor 10 concentration. And you can see here, if you look at that slide here, that on the right here, it's a single patient. And the black curve, the black bold curve is the old PT INR, and the red bold curve is the Fiix-NR. And you can see, like here at this time point in this patient, his INR rises sharply and he gets an INR of 10. That's because factor 7, the blue, has decreased to almost nil. But at the same time, the Fiix normalized ratio does not rise more than to about 4. And you can see that there is a slower decrease in factor 2, the red here, and factor 9. Obviously it wasn't enough for us to develop this test and show it in a few patients. So we had to somehow prove the concept, and we decided to make a blinded trial. So we designed a blinded randomized trial with 1,143 patients that were randomized into 2 arms. One arm was monitored with a new Fiix normalized ratio, and then there was a control arm that was monitored with the standard quick PT INR. The laboratory reported a blinded monitoring method, so neither the patient nor the monitoring staff knew which test was being used in the particular patient to monitor their warfarin. And basically, this is what we found. The first one, we found there was a decrease in the variability of the INR. There were fewer tests and fewer dose changes in patients that were monitored with the new test, the Fiix-NR. And there was an almost 50% reduction in total thromboembolism in patients that were monitored with the Fiix-NR, that's the blue, compared to the control arm, which was the old PT INR. And you can see that, but the bleeding was just the same. So we did not see an increase in the bleeding and no decrease in the bleeding, but just the same. But the interesting thing was that you can see that nothing happens for about 6 months, and then the curves split. And so we decided to do a secondary analysis where we left out those first 6 months, which we consider to be some kind of a washout period. And when we do that, then actually the difference remains. It's actually statistically significant. It's significantly superior. The numbers I showed you before are statistically non-inferior. But we think that the explanation for this is that not all the patients are being switched right away. The laboratory changes the monitoring method. Then it takes about 2-3 months until all patients have been switched to the new test. And then it takes a few more tests for the stabilization of the effects to take place. But in any case, so we had this. So we had these results: a major improvement in thromboembolism by about 50%. And based on that, we decided, why are we using this old PT if we get this much improvement in our patients? So we actually switched all our patients at the Landspítal in Reykjavík to Fiix monitoring in 2016. And we then decided that do a confirmatory study, which is sort of a before and after study, which we can call Fiix in Warfarin practice study. That's a real life study. And it's a single cohort interrupted time series pre and post study. So we had 2,667 patients, and we studied the incidence of major bleeding or thromboembolism at 30 consecutive monthly event incidences over time. Then there is an interruption when the laboratory switches the monitoring method. Then there is a washout period of 6 months, and then we compare the 12 months the last 12 months of the PT-INR treatment to the 12 months of Fiix-NR monitoring. And basically what we found using segmented regression was that we found that there was a 58% decrease in thromboembolism, but there was no change in bleeding. And if you look at here is a relative risk plot, which shows that there is a major decrease. It's in the range of 45 and up to 62% decrease in thromboembolism. And most of it is actually statistically significant. There seems to be also a slight decrease in bleeding, but this is never anywhere close to significance. So there may be a difference in favor of the new test, but we don't have statistical power to show it. Also here in the data about the stabilization effect, you can see that there are fewer annual tests when we monitor with the new test. So about 12 annually as compared to about 16 or 17 previously. The test interval is longer. The dose adjustment interval increased from on average 60 days up to 90 days. And there's not much change in the timing range, but the measure that we have of anticoagulation variability is reduced about 35%. So now I'm going to tease you a little bit, because now I'm going to look again at this study here, the American study of 130,000 people, which showed that there was a lower incidence of ischemic stroke in patients taking the new agents. And if there would be a 50% decrease in thromboembolism, if we use the new method, this is what it would look like. Now that's intriguing, but this, of course, is just guesswork, and we it may be wishful thinking, but we are working on a study comparing all oral anticoagulant use in Iceland, and actually I can tell you that there is a hint that this may be true. So this is my final slide, and basically I think you can read this, but we can just leave it up here. But I think many of the key opinion leaders in the field, they will think that my conclusions are controversial. But based on our 2 clinical studies that found a 50% reduction in thromboembolism during fixed warfarin management compared to PT warfarin, I can contend that the fixed warfarin has the potential to provide patients, health insurance, and society with better clinical outcome than is possible to achieve with other currently prescribed oral anticoagulants. And that was my final slide. Some of you that are at my age, you remember that we went to see the cartoons on Sundays, and this was the end of it.
Thank you so much, Dr. Paul. That was wonderful. Great piece of work. You spent your large number of years working on this, publishing this, and now educating this to us. Thank you so much for sparing your very, very early morning of this Sunday to do this for us. So we have some of our colleagues who may be interested in asking you some questions and discussing with you. First of all, once again, thank you so much. We begin with Dr. Rucha Patil.
Good afternoon, one and all. Firstly, congratulations, sir, for this new improved test, which is going to be beneficial for all our patients. And thank you for the very informative lecture. So my question is that in our department at ICMR NIIH, we have done a very large series of patients on warfarin was studied, wherein we found a change in the cytochrome and BKORC11639 genotype, strongly associated with the increased PT-INR or warfarin sensitivity. So the question is, does this association of warfarin dosage with the change in cytochrome or BKORC genotype remain the same for this test as that of PT-INR?
Well, it's a good question, and we intended to study this, but we have all the DNA frozen away and we have not gotten to it.
All right.
But basically what I think is going to be the answer is that this will mainly influence the dose range that a patient will need, but it's not going to influence the variability a lot. There are so many factors that influence the variability. There are food interaction, drug interactions, and then this confounding influence of a factor that we should be ignoring, which is factor 7. But I think that's the only way I can answer it.
Okay.
I've been after the geneticists to get them to finish working on all this DNA, but we haven't gotten to it.
Okay, sir. Thank you.
Sorry.
Dr. Chandrakala.
Thank you, sir, for a wonderful lecture. We learned a lot actually from basics to very nice technique. So we see patients of liver disease on warfarin for the various reasons. Is this test will be useful to monitor INR in patients with the liver disease because they already have altered PT INR in these patients. So there is something called liver INR was used in the past, but that is not usually available. So how is this test will be useful in such patients, sir?
I don't really have any data on that. And we have relatively few patients with major liver disease in Iceland. For some reason, we do not have a high incidence of cirrhosis. There is what I can only tell you what I think, because we have done studies comparing thrombin generation in vitro or ex vivo to in patients that comparing that to the Fiix-NR versus the PT-INR. And the Fiix-NR corresponds much better to the thrombin generation. So leaving out factor 7 will reduce the confounding. But if that's going to be clinically better in the liver patients, I don't know. I think it will be. In our case, we have a different kind of a liver. Since we started using this Fiix-NR for monitoring, we had to also provide a different INR, which we call a liver INR, to the gastroenterologists, because they use that to classify their cirrhosis patients. So our liver INR is actually the old PT. And then the INR for anticoagulation, that's the Fiix-NR. I know I can't answer your question, but I would love to know.
Thank you, sir.
Yeah.
Thank you. Dr. Bipin.
Hello, sir. This is really a wonderful discovery and a great presentation. Really enjoyed it. Sir, I have one question. Like you have in your presentation, you have shown a good correlation of the factor 2 and 10 assay levels. So in the absence of the kits as of now, can we use the factor 2 assay or 10 assay independently to correlate, or how does it correlate with the Fiix-PT if we compare it with individual factor 2 or 10 assays?
Yes, I think you probably could, but it's going to be very expensive with all the factor deficient plasma that you need to do that. But there was Bruce Fury and his wife, Barbara Fury, in Boston back in the 1980s. They made a new test called the native prothrombin time test, NPA. And this was an ELISA. So it wasn't a very convenient test for the clinical purpose, but they found that and then monitoring the native prothrombin antigen is the part of the prothrombin or the proportion of the thrombin that has not been influenced by the vitamin K action. And they could use that, and they showed that they could improve the management and improve the stability of patients on warfarin. These were small clinical studies, but this was never manufactured as a commercial test. So I don't know what happened to it, but that of course indicates that you could use a factor 2 measurement to monitor warfarin. In our case, because these ex vivo and in vitro studies showed an effect of both factor 2 and 10, we decided that the test should reflect the combined effect of the two. But I think you could possibly use one or the other.
Right. Thank you, sir.
Thank you, Bipin. Dr. Farah.
Thank you, sir, for taking us through this lovely journey from the very basics. One of the major problems with warfarin has always been the interactions with drugs and food, and of course, the monitoring. So regarding your test, and the other advantage of the DOACs is that they don't need monitoring, but one is always one wonders how efficacious it can be or whether there is any limit whereby it can cause side effects like bleeding. So can your test be extrapolated, or have you done work regarding monitoring the DOACs with this test?
Yeah, yes.
Useful?
I'm having some kind of a trouble now. Can you hear me?
Now we can hear you well, sir.
Oh, okay. So I just,
Yes,
there was something that happened with Dr. Genia's voice, but I think I got the question. Yes, we did publish a study in the Journal of Thrombosis and Hemostasis back in 2017, I believe, where we showed that you can use our test, and you can also use the prothrombin time to estimate an effect of the new agents. But if you use an undiluted thrombin time, it's a bad test. So it's really not worth much, even if in some patients, we get some influence on the PT. What we did is that we diluted the thromboplastin. So you have to dilute, you have to do a diluted thromboplastin time, and then you have a test that you can actually calibrate to supply concentrations of the new drugs. And you can read that in the JTH publication, and we are still working on that. So I have a student working on that to see if we could make that a clinically useful test, because it would be mostly useful if you could provide the results as seconds or some kind of a percentage of anticoagulation activity, rather than having to calibrate for each individual drug. But this is possible. But it's not only possible with the new fixed test, it's also possible just with the regular prothrombin time. So, but you have to dilute the thromboplastin about 1 to 1,000.
Right. Thank you, sir.
Thank you for that. Dr. Srimati.
Hello, sir. After your extensive lecture, if I make a statement that the contribution of factor 7 to thrombin generation is minimal, is it a right statement?
Yes, it's minimal unless you hit a concentration of less than 2%. And when you think about it, if you think about patients with factor 7 deficiency, they hardly ever bleed unless they have severe factor 7 deficiency. So they are in the range of 2% or less. Then they have a bleeding disorder. The same thing with factor 9. You have severe hemophilia once you're below 1%. And you don't have a lot of bleeding if you're between 1 and 5%. So these, the factor 9 and factor 7, they activate the prothrombinase, but it's really the prothrombinase activity, or the tenase activity that we are interested in. It used to be called the common pathway. That's where the anticoagulant effect is. But I sort of think of factor 7 as being a match, and you have to bring the match. You strike the match. You have a little bit fire. You bring it to a wick, and then the bomb explodes once you activate the common pathway.
Thank you, sir.
Thank you, Dr. Srimati. Dr. Cecil? Unmute yourself, Cecil. Unmute.
Sorry. Just for clarity, sir, when you use INR, it is usually calibrated to oral anticoagulant. When you use PT, it is usually used for liver disease, because the INR is a number that you calibrate for with the ISI number that is there in the vial. Is it not? So therefore, the liver chaps use INR. What is the reason? They should actually be using PT, not INR. Is it not?
I totally agree with you. And I've tried to argue with them, and it's to no avail. And the gastroenterologist world, they have decided that they will use the INR to define if somebody has cirrhosis or not, or how severe the cirrhosis is. It makes no sense to me. The INR is designed simply to monitor warfarin
Oral
or
antiplatelet,
vitamin
yeah.
K antagonists.
Yeah.
The liver, the PT is sensitive to fibrinogen and factor V also, and they may be reduced in liver disease, of course, because there's a synthesis defect. But this makes no sense to me. But I'm unsuccessful. That's why I actually, when I provide a PT, and they can also ask for a PT INR, and we call that liver INR just to make the gastroenterologists happy.
Okay.
But you are totally right.
Thank you, Cecil. Dr. Dheeraj.
Yeah, good morning, sir, and very excellent lecture. And it gave us another perspective, especially if patients who are already on warfarin would be like, with the newer guidelines, would be pushing them towards DOACs. But now if they are comfortable, we would suggest this test. But do you have anything like easily some meters or something which we have for prothrombin time? Because availability of this test in our country will be little difficult. If at all we tell the patient, especially those who are having higher thrombogenic risk, I agree. This would be definitely a better test as compared to people who are non-valvular AF. Still, it will be difficult with the guidelines still not approving it to go for warfarin and with this test. So I just wanted, is there any convenient way, like the meters which we have, devices for measuring prothrombin or PTINR, this thing, we have some devices when lab facilities are not there around?
Yes. I'm not sure if I heard the question right, but basically the Fiix-PT, the way it is provided now by the manufacturer, it's what we call a wet test, meaning that you can do it on the coagulation instruments, and it can be very easily automated. However, it's not available as a point of care test. But the manufacturer, Heart Biologicals, they have worked a lot with sort of local, smaller instruments and providing, local access to coagulation testing. And I know they've been in Thailand and Indonesia. I don't know if they've been working in India. Of course, they should be. But can you use this test and say that you're going to break the guidelines and say, no, we're going back to warfarin? I mean, guidelines it's not a law. Guidelines are written by people, and people that have done studies. And some of the people writing the guidelines have actually been working for companies. So it isn't as if it's pure science that decides, what you're going to use. There's no money at all in warfarin. Nobody makes a profit by using warfarin. Only the patients could make a profit. So if there's a 50% decrease in thromboembolism without an increase in bleeding, society could decide, no, these guidelines are not correct. But I'm not going to be the one. And I would always reject being a part of a panel that would write any kind of guidelines. I don't know if Paul Bates from Heart Biologicals is here. He might be here, and he might be able to tell you a little bit about the possibility of this becoming an easier test to use as a point of care test. Paul, are you there?
Yeah, hi guys. Yes, I'm here. I'll put my video on. Apologies, it's a little early in the morning in England. I'm in my night suit, I think you would call it. Yeah, so we have two initiatives going on. We have already commercialized the wet test that Pal talks about. So this test is designed to be used on laboratory analyzers and is capable of delivering the Fiix-PT INR results. It uses a straightforward protocol, but very much designed for automated analyzers. We also have an initiative now set up with a local university in the north of England. And what we're doing there is trying to take the Fiix technology and apply to a semi-dry phase reagent, which would be easier to use in the field. So rather than using a test that then has to be the patient has to be managed around a laboratory, you could then take it to a near patient situation. And that is something that we are working on. Whether it works in a traditional coagulometer or whether it moves towards some kind of dry phase, this wouldn't be a strip in the way that some of the other commercial meters work. This would be probably using what we know as bead technology. So this is where you have the chemistry, if you like, fixed on a bead rather than in a strip. But it would be dry, if you like. It's not going to be designed where you have to reconstitute reagents and make up to volume and that kind of thing. So that's kind of where we see the test developing to. And that's pretty much where we are with it right now. Yeah.
Thank you. Dr. Srimati, you have another question? If no, then Dr. Bipin.
Yes. Given the differences in the PT-INR and the Fiix-INR, particularly in the initial periods of anticoagulation, so from the laboratory perspective, what would you suggest? Like, what is the bottom line? Should we be doing, whenever the test is available in India, should we be doing both the PT-INR as well as the Fiix-INR, or should we be switching completely to Fiix-NR over a period of time? What would you recommend?
Well, you will have to use the old PT for diagnostic purposes, because if you're screening for coagulation defect, you're gonna use the PT. If you have the Fiix-PT available, there is no meaning in doing both in the patients. You would only use the Fiix-NR. And the one thing I should warn you about is that because the Fiix-NR is only sensitive to factors that have a long half-life, Fiix-NR will move slowly. It's a slow wave, and during initiation, it will not rise as fast as does the PT-INR. This is the same thing after those adjustments. So we have a slightly different protocol for initiation. Once you see that it's on the fourth day or so, if you see that the INR is 1.4, we start lowering the dose, and if it hasn't risen, then we will raise the dose. So we have actually published this in the Journal of Thrombosis and Thrombolysis last year, just to our new initiation protocol. But there would be no meaning in using the PT as well. No.
Thank you, Dr. Cecil.
So just for clarity again, would you have a nomogram which will actually read off the Fiix-INR versus the normal INR?
We don't, but we have sort of published it in our publication in 2016 in the Journal of Thrombosis and Hemostasis, where we are doing these thrombin generation assays. So you can sort of compare it, but you will get, but it's not a fair comparison, because it's apples and oranges. It's not comparing the same thing. We are monitoring a different effect. The one thing I contend is that with the new test, because the concentration of factor 2 and factor 10 will tell you if you're anticoagulated or not. The new test, once you hit an INR of 1.8, you are anticoagulated, and you can stop using heparin, or something of the sort if you're giving it simultaneously, because this test will always tell you if you're anticoagulated or not. Whereas with the PT, as you know, with the short half-life of factor 7, you may not be anticoagulated at all. It may only be factor 7 that has decreased to prolong the INR.
So you'd say that if you have a patient on warfarin and if the PT if the INR is 1.8, you would leave him alone?
Yes, no, then I would say he's anticoagulated. I can stop the heparin. Okay. Yes.
Thank you. Dr. Akanksha.
Yeah, very good morning, sir. Thank you so much for your talk. So I'd like to ask, what are the INR ranges that you are following for the Fiix-NR testing? And is it the same as the PT-INR, or are you following some lower ranges for this particular test?
Okay, if I understand it, are you asking if the target ranges are different?
Target range.
Yes.
Yes.
Well, I would love to know. My feeling is, and I would love to know, is that we could possibly get a similar efficacy, but decreased bleeding by lowering the target range. Like lowering the target range, say to 1.75 to 2.75 as opposed to 2 to 3. But we have not done it.
Okay.
There is a study, I think it's only a single study, which showed that a lower range of PT-INR in the range of 1.5 to 2.0 was worse than 2 to 3. But I think they chose a wrong range. They chose to use too low of a range. So they should have, and also it's a very narrow range, 1.5 to 2. But we would love to do a study where we would see if we could actually lower the target range and see if we would still maintain efficacy, but that we could reduce the bleeding. As most of you know, once, and we have some patients where we think they are high risk, and then we use a lower range. We use an INR of 1.5 to 2.5. But we have no study behind that. It's just our sort of feeling that it works well. But what we know is that it's much easier to monitor patients at the lower range than it is if you have with a higher range, because a higher range is actually a more narrow range. It's just an exponential relationship. So yes, we would love to do that.
Thank you.
Thank you, Dr. Dheeraj.
Yeah, my question was also on the similar lines, half of which has been answered by Dr. Pal. This studies which you have elucidated, sir, the thrombotic risks were definitely less, but the bleeding risk was similar. So I think the hypothesis which you are saying is that we are keeping more higher INRs as a range, which we should lower. Any other reasons why do you think the bleeding events did not reduce much? That's what we could see.
Well, I think that actually, the reason why we are getting a reduced thromboembolism is that there is more anticoagulation. The patients are more consistently anticoagulated. And but the reason why bleeding does not increase with increased anticoagulation is because we decrease the fluctuation. The variability is decreased. So we are sort of lucky in that sense that we have increased anticoagulation level, but at the same time we have reduced the variability, and the variability does associate very strongly with bleeding events. So I think that's the best explanation I can give you. It's a speculative explanation.
But at the same time, I was expecting, sir, that the bleeding events would be less, but they weren't. They were almost similar. That's what my concern was there, because we are always answerable to the patient. We are preventing one thing, but then this is an adverse event of the drug. If because of the disease something happens, then it is more acceptable for the patients.
Well, it's tough luck. Anticoagulation is a Russian roulette. You are anticoagulating someone because they are at the risk of dying or getting a major disability from a stroke or something. Anticoagulation with the current agents comes at the risk of getting bleeding. And in our studies, we have seen that the ICH rate is similar with the new test as it was with the old test. And as you all know, it seems to be lower with in most studies with the DOAC drugs. But at the same time, we are seeing a much lower rate of thromboembolism. So if you think about that study that I showed you from America from SPAC, where they had 130,000 patients, they were able to prevent. They prevented 1,400 cases of ischemic strokes, but at the cost of increasing intracranial hemorrhages by about 50, from 320 to 370. So welcome to clinical medicine.
Thank you, Dheeraj. Dr. Pal, what I would like you to do now, I have to answer the quiz to the postgraduate students. Meanwhile, if you can go through the questions, put in the question box, and I'll come back to you in 2 minutes, and then whichever question you want to answer, you can answer those questions. Okay. So I'll just share my screen to answer the postgraduate quiz. Okay, so we come back to the quiz that was put to you. As you will remember, this was a quiz regarding sickle cell trait, and you were given 7 statements and you were asked to pick up the wrong one. The first statement is that hemoglobin S is a point mutation in beta globin chain. A is replaced by T at codon 6 that replaces glutamic acid to valine amino acid. This is a correct statement. So that's the basic science. There are 300 million people of sickle cell trait in the world is correct. 1/3 of them live in the sub-Saharan Africa is correct. And in US, there are 3 million people with sickle cell trait, correct. So the second statement is also correct. This is a common statement known to everybody that sickle cell trait does give protection against death by falciparum, and that's how the sickle cell disease has become prevalent in the tropical belt. We'll come back to the fourth a bit later. In the US, there is mandatory newborn screening in all the states before a newborn is discharged from the hospital. So this statement is correct. Number of statements or conditions were mentioned here which can occur in sickle cell trait subject, I won't say patient, and that is correct. Each one of these, whatever complications were put here, hypostenuria, renal papillary necrosis, bacteriuria in female, hematuria, even a cancer like RMC, chronic kidney disease, thromboembolism, infarcts, rhabdomyolysis, and heat-associated collapse, and unexpected sudden death in athletes, police, or military following exertion. All these have been documented. So this statement is correct. Large number of you answered that the 7th statement was wrong. That is, despite these complications, the average life expectancy of people is same as that of normal population. This statement is correct. There is no decrease in life expectancy of a sickle cell trait despite all this complication. So the problem was in the statement 4. The hemoglobin S percentage is usually around 40. That is correct. If there is iron deficiency, this goes down, is also correct. It can go down even up to 20%. If there is a beta thalassemia carrier state, it does not go down, it rather goes up. So sickle beta thalassemia will have hemoglobin S of anywhere from 50 to 98%, not below this. It's the alpha thalassemia. If that is associated with it, then it goes down to, and it can go down to 20%. So this beta was the wrong thing. It's the alpha thalassemia carrier state which reduces this. So the answer expected from you was 4. Unlike last time where everybody failed, this time we have correct answers. 7 of you have given the correct answers. 2nd to 7th are put up over here in the order of timing. So the second fastest was Biswa Prakash Patri, and then Sona Nair, the Savitri Singh, Virti Shah, Babita Sodi, Ketan Naithani. So congratulations, all of you have given the correct answer. And then comes the winner, the fastest finger fast, and that is Dr. Sweta Rajpal. She's DM, hematopathologist, assistant professor, hematopathology lab at ACTRAC Tata Memorial Center, Mumbai. So Dr. Sweta Rajpal, heartiest congratulations to you. We'll send you your winning prize, and thank you so much. So that was the quiz. We come back to Dr. Pal. So from the questions in the question box, whatever you want to answer.
Well, first there was a question why the double I in the Fiix. And this is simply because it's a Roman factor 2 and Roman factor 10. So the Fiix deficient plasma is a factor 2 and 10 deficient plasma. So that's the sort of the word game that we are using, but we pronounce it Fiix. Then there was a question about a young male with cerebral venous thrombosis. All thrombophilia workup was negative, and how long should I anticoagulate such a person? In my mind, it can be a quite serious disorder, and this is a young male with an unprovoked thromboembolism. I would anticoagulate such a patient indefinitely. If it was a woman who would develop this in association with a pregnancy or on an oral contraceptive pill, I think you could then say there was a temporary risk factor and you could stop after 3 or 6 months. But for this kind of a patient, I would continue. there was also a question there about what do we do when we are escalating the dose of warfarin, and when we sometimes have patients. We will, we can raise the dose. We can go as high as 18 or 20 milligrams. It's really the INR that will tell you if the patient is anticoagulated or not. It's not the dose. So I don't think it's a treatment failure. It's just that this person's metabolism is of the sort. But the patient becomes very wary, because they have to take a number of pills. Is there a dose where you stop raising the dose and switch to a different agent? I don't know. I really don't know. Yeah, those were a few questions, but there is actually more. I don't know how much time you got, but yeah, there was a question there about the anticoagulation choice in pregnancy and during lactation. We always use low molecular weight heparin during pregnancy, and if the patient is on warfarin or if they are on DOACs, we tell them that as soon as we know that they are pregnant, we switch them over to low molecular weight heparin, which will not cross the placenta. So there is it's not considered risky, although there actually are reports of osteopenia or something of that happening with heparin. But that's what we would do during lactation. You can use warfarin. Warfarin is not excreted in the mother milk, so you can do that. But otherwise, you're left with low molecular weight heparin until they stop lactating. You would not use a DOAC drug because that's going to be excreted in the milk. To what time should warfarin be titrated with heparin? I think they're asking how long we should overlap the two. If you're using the PT-INR, generally speaking, you overlap for about 3 days or so. And that's because you're waiting for factor 2 and 10 to decrease, and not only factor 7. But with a new test, we can actually stop earlier, because as soon as, if we are convinced that it's on the upswing, then we can just stop. Once the INR hits 1.8, 1.9, we just stop the heparin. What about how should we monitor warfarin in cirrhosis patients? Well, it's a difficult one, and it's the best thing that we have is warfarin, I guess. But we would not use the DOAC drugs typically in liver cirrhosis patients, and sometimes we could use low molecular weight heparin. And we could then monitor anti-factor 10A units, which we use increasingly. We use anti-10A units rather than using the APTT, because I think that gives you a better estimate. Then there was a question here. What would be the target range in liver failure patients with veno-occlusive disease? I think it would be the same. And if there was evidence of worsening, I might increase the INR to 2.5, 3.5. I will hardly ever go up to a higher range, because then I start getting into bleeding problems.
Right. So thank you so much for answering all those questions. So your lecture, your interactive session with the faculty here, and answering those questions from the audience. So Dr. Pal and Paul, both of you, thank you very much for contributing so immensely to the success of this educational exercise today. If at all there are any questions from the faculty here left, your difficulties, we have a couple of minutes.
I'm going to say something, because I've already told Mohan that the Icelanders and the Germanic people, they came from Azerbaijan. We know that from our old sagas. And if you look at my name, the Önundarson, it's the same name. So my father's name is Onund. Same name as Anand in Indian or Sanskrit, meaning peace. And so you can tell that these names, they stem from Azerbaijan, maybe about 20,000 years ago. But it's been my pleasure to see all of you people in Bombay. I've never been to India, but it's just great to be there virtually. And thank you for listening to me.
Thank you so much. There will definitely be an opportunity after the end of pandemic is over to invite you. India is quite lovely and beautiful. We'd like to show you some places here and you will enjoy it. And we will create that opportunity, definitely. And thanks once again for sparing early morning on a Sunday to Paul and Paul. Yes, thank you. And thanks to all of you for making it so interactive, all our delegates. And thanks to RPG for supporting our academic activity. Bye-bye and have a wonderful day.
Thank you.
Bye,
Thank
everyone.
you. Bye-bye.
Bye-bye.
Bye-bye. Thank you.